Hello, it's Dr. Ken Gillman here, doing another of my videos that relates fairly closely to much of the detailed material that's on my website. So for those who aren't familiar with my website and of course my scientific publications in the peer-reviewed scientific literature, don't forget that much of the material and much of what I say is backed up by well documented and referenced material. This particular video has been stimulated by the recent emergence of there have been waves of another controversy about ECT treatment. And since I've been finishing my summaries of the pharmacology and efficacy of things like MAOIs, it's highlighted for me more and more that the methodology of science is something that needs to be thought about a little bit more by a lot of people. And understanding what's going on with all of that helps you to see why there seem to be such a lot of discrepancies between, for instance, what's in the guidelines, treatment guidelines, which are ubiquitous now, and most doctors seem to feel obliged to follow them, although they're for guidance, they're not supposed to be diktats. But sadly, so many people seem to feel that if they don't follow the guidelines, they're going to come in for censure or criticism in various different ways. And that's a very real concern that doctors have. So the whole business of what exactly is the evidence that we use to decide how to help patients is a really, really important question. And because I've been writing quite a bit about this in the last few months, when this ECT controversy re-emerged, it made me appreciate that what I'm saying about the value of MAOI type drugs in treatment of severe depression, and less severe depression, but in biological depressive disorder, has a lot of parallels with the controversy about ECT. So I want to talk a bit about that and to help people to understand how it is that the experience and opinion of a lot of very learned and experienced doctors in many different countries all over the world diverges quite significantly from what's in the guidelines. I must admit, many of the treatments that I think are the most effective treatments aren't in the guidelines. Perhaps the first example of that is the old tricyclic antidepressant Clomipramine, which was really the first SNRI, and in fact, in my opinion, is still the only true SNRI, because I think duloxetine and venlafaxine have doubtful claims on that title. And it was obvious to many experienced psychopharmacologists who specialised in treating difficult cases of depression when I was in the early phase of my career in the UK back in the 70s and 80s. Most of those experienced clinicians regarded Clomipramine as undoubtedly being the most effective tricyclic antidepressant. And I've held that view ever since then. But that's not reflected by randomised controlled trials. So there's one, going way back to the beginning of psychopharmacology almost, one example of the glaring disconnects, the incongruities between what experienced clinicians think and what's in the guidelines. The gods save us from guidelines. Okay, what exactly are guidelines? Well, the quick answer is, the accurate answer, that they're largely compilations of opinion derived from randomized controlled trials. let's not dwell on exactly how you define what a randomized control trial is, whether it has to be blinded, placebo control, blah, blah, blah. But essentially that mode of investigation of comparing one drug with another, with lots of rating scales that really only measure things in the short term, has become the be-all and end-all of scientific investigation. Because if you look at the literature of all the hundreds of thousands of research studies published, RCTs make up, 90% of them, huge proportion. And you don't get any prizes for guessing that, especially in this last 3 decades, a vast majority of those trials are subsidised, run, organised, analysed, and the data about them is held by large pharmaceutical companies. And the purpose of those trials is exclusively, I think that's fair to say, exclusively, to get drugs over the finishing line, i.e. approved by the FDA, which means producing a few trials that show that they've got a few paltry points of advantage versus a placebo or something else on the ubiquitous Hamilton rating scale for depression. And that's all they have to do to get over the finishing line. Well, frankly, that's got very little to do with science. RCTs are a methodology for comparing one drug to another, often in a less than fully adequate way. They've got virtually nothing to do with scientific investigation and establishing cause-effect relationships in science. And let me just emphasize how important that is by telling you, not reminding you, because most people don't know about this, by telling you that one of the biggest advances in the science of causality that's been made in the last decade or two is by a gentleman called Judea Pearl. He's held posts, I think, at Harvard and now at UCLA or something. Anyway, he's held prestigious posts. He's in the area of mathematics and IT. He received the equivalent of the Nobel Prize, but since IT and mathematics doesn't have a Nobel Prize, it's called the Turing Award after Alan Turing, the famous father of computing who played a part in the Enigma Bletchley Park secret business in the war. So the Turing Award, very, very prestigious. Pearl won it in 2011, if I remember rightly, for his work on causality. So he's probably the most significant figure in that field in the last couple of decades or more. And a statement I read by him struck me, and I'll reproduce it from memory as best I can for you. Science is nothing without causality. It is the sine qua non of all scientific advancement. What he means by that is this. Simply comparing one drug to another or to a placebo might reveal something about whether it appears over the course of time that those treatments have been administered that one or other of those groups has improved a little bit more than the other one. But generally speaking, that's not a very helpful exercise because often you can't prove the groups are homogeneous to start with. In other words, they're made up of some people who will respond and some people who won't, which contaminates the whole thing. And all sorts of other factors influence whether people appear to improve, especially when the main measure, as it is, of course, in psychiatry, is a very subjective rating scale. People haven't yet employed more objective criteria for the improvement of depression. It's been rather slow coming, in my opinion. So you've got a whole lot of factors there, and then you've got factors like regression to the mean. Now, I'll say a brief word about what that means, because it's terribly important. When are you most likely to go and see the doctor? Well, So many visits to the doctor are caused by sort of relatively chronic conditions, whether it be back trouble or arthritis or whatever. You're most likely to go to see the doctor when your symptoms are worse than usual. And what's the likely progress of your symptoms over a period of time? They're probably going to get a bit better again. So if you take a group of people like that and you start them in a trial largely because they presented because their symptoms are worse, then inevitably their symptoms are going to get better over time to a significant extent. I don't mean completely better, but if you start doing all these pain rating scales and depression rating scales and blah, 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 you'll find there'll be improvements just as big as are accepted as evidence that antidepressants are working on those rating scales over a period of a few weeks. And that's purely because they were just going to get better anyway. I have to say a few words in this discussion about the poor term, the placebo effect. I honestly think it would be better if that term was completely abandoned. It's poorly defined. The mechanisms behind it and what effects it has have been very poorly investigated. And it's held by many people, of course, to be to do with psychological expectation and having hope that you're going to get better and stuff like that. Well, of course, that's a statement of the obvious, isn't it? If you're pessimistic, you're probably not going to get better, and if somebody can encourage you to be more optimistic, you're probably going to feel a bit better. The question is not whether you feel a bit better on a subjective rating scale, but whether your actual illness is getting better. Is there really a long-term reduction in your hypertension? Is there really a long-term reduction in your uric acid level that's causing your gout? Is there really a slowing of the process of your arthritic change that means you'll have less pain into the future? Years, not a few weeks. And of course the answer is there's absolutely no evidence for that. What the evidence of this wretched so-called placebo effect is that it has a much bigger effect on short-term subjective symptoms than it does on actual illness processes and aspects of those illnesses that can be measured more reliably and objectively. And that suggests, of course, that it's contaminated by a whole host of factors to do with, both the patient and the doctor being optimistic about the assessment and not doing the rating scales quite as objectively as they might be done, and so on and so on and so on. So there are some things that are related to psychology and the placebo effect, and then there are some things like this, the thing I mentioned before, regression to the mean, about this regression to the mean. And so lumping it all together under the placebo effect is unhelpful and unedifying. And it tells you nothing about what the mechanisms involved are and how to manipulate those. And that gets us back to our friend Judea Pearl. And what he's emphasising is that if you're going to learn about something, you've got to have a theory about the mechanism. It can't be black magic, like the placebo essentially is. You've got to propose a scientific mechanism by which this change comes about, and then you've got to manipulate the causal variables that relate to that and see what change there is in the outcome of your experiment. That's proper science. And that's just what's not being done. Well, not in clinical trials. But in a sense, you can say that's exactly what I'm doing when I'm treating a patient clinically and doing a proper clinical experience experiment. Now, it's become popular nowadays to denigrate expert opinion and clinical experience. And that's quite correct in a sense if that experience is not properly documented in a systemic way and if objective measurements aren't done to back it up. But assuming that is done, then the way one might treat a patient in the normal course of a treatment course of trying to get depression better, for instance, is you try various different drugs and you treat people on an individual basis according to what suits them and what doesn't. And you observe, especially in a dose-effect relationship and over a discrete period of time, whether or not the drug produces the expected effect. And that's a kind of push-pull experiment. If I give you a tablet and after a couple of months you get a little bit of improvement, then I'm not going to be very impressed by the likelihood of there being a cause-effect relationship between the administration of that drug and you getting better. Because, of course, we know more or less how drugs work, and we have an idea of what the time scale of their pharmacological effect is. And really, if somebody's going to respond to an antidepressant, it's pretty likely that you're going to notice significant improvement in a couple of weeks. And if you don't, the chance of there being a cause-effect relationship between the administration of that drug and their improvement becomes somewhat less. So if you then reduce the dose and they got worse, and then you increase it again and they got better again, you would be doing a kind of push-pull experiment that I'm sure Judea Pearl would approve of, which would substantiate the cause-effect relationship between the intervention and the outcome that you're measuring. I won't go on about that unduly because it's a complex business, but I hope that transmits some idea of how opinion developed from good clinical practice and clinical experimentation and bedside observation can be a very valid way of gaining knowledge. Now, clearly, that kind of methodology can be extended into a more formal clinical trial, and indeed, so it should be, in my opinion. So, for instance, getting back to this ECT business, a great majority of people who improve with ECT, you see a very definite improvement within a discrete period of time, like 4 to 8 treatments, 2 to 3 weeks. And also, when I say you see improvement, back to this business of subjective rating scales, one of the central symptom, not one of the central symptoms, the central symptom of severe depression is psychomotor retardation, reduction of drive, energy and motivation, with a concomitant decrease in your ability to experience positive feedback, i.e. anhedonia, the reduced ability to experience pleasure. That is absolutely the heart of biological depressive illness. Now, those are objective changes that you can see when people are improving. When people have got severe depression, they, in some ways, look and behave like somebody with Parkinson's disease. They're flat in their facial expression, they're slow in their thinking and their physical movement, and you really don't get much expression out of them at all. And yet when they get better, then, oh, doctor, good morning, doctor. The difference is quite objective and quite striking. So if you concentrate on those kinds of symptoms and also on people's functional capacity, their capacity to actually do those activities that they would normally do if they were well, then you get a rather more reliable assessment of whether people are actually improving, not whether they just subjectively feel better. Indeed, I used to upset people who worked with me and the patients sometimes when they talked about how they were feeling. And I used to say sometimes, I don't care how you feel. I want to know what you're actually doing. You say you feel better, or you don't feel better. You say you feel better, but are you actually doing more? Are you able to concentrate more on reading your favourite book? Have you watched your favourite television programme? Have you rung up your friends? Have you taken your dog for a walk? You don't have to be Einstein to figure out how you can very simply, in everyday practice, get a whole lot of measures like that of whether people really are doing more, not just saying they feel a bit better. I hope that gives you an idea of, basically an idea of how second-rate most rating scales are. Because when you start to look, for instance, at the Hamilton rating scale for depression, you can look at it online if you want. I'm sure there's a link to it in one or more of the commentaries that I've written on my website. If you do that, you'll see that a vast majority of the questions don't relate to those fundamental symptoms of drive, motivation, energy and anhedonia that I was talking about. Almost all of them are peripheral symptoms that can be affected by all sorts of other things and aren't really at the heart of the matter. And it's always puzzled me a bit, I suppose, that biological psychiatry hasn't done more to develop more objective tests of psychomotor retardation. But they are. Well, actually, it doesn't surprise me because, of course, back to this business of the influence of drug companies and how RCTs are really a quick, convenient methodology for them to get drugs over the finishing line and get them approved. And, of course, what goes absolutely hand in hand with that is rating scales. No individual drug company is going to do the basic research that leads to the development of a better new rating scale. They're just going to use whatever everybody accepts because the FDA accept it and most clinicians think it's the bee's knees, and so they all use the Hamilton rating scale for depression. The fact that various eminent experts over the years have pointed out that it's actually not very good, that just gets lost. So that helps you to understand how the reality of research doesn't reflect the desirable underlying standards of good science. So, back to the business of this row, this, it is a row really, isn't it, about ECT. I think it's a little unfortunate that Kirsch and Reed have expressed their opinions in the way that they have. They're making a great fuss about how objective they've been, but if you look at the comments I've made in one or two things I've written about them, they're actually quite hyperbolic. You know, appallingly bad evidence and saying it shouldn't be allowed and all the rest of it. It's a bit over the top. The other thing that is relevant to observe, this is not ad hominem stuff, but opinions people express, you have to consider them in relation to what's their knowledge and experience of the wide range, of underlying science that lies behind this. And this comes back to why RCTs are such a limited methodology. Clinical science has got to do with anatomy, physiology, evolution, physics, pharmacology, statistics. There are a host of scientific disciplines which impinge on those things. And you can't just approach an RCT from an atheoretical basis as if it was just comparing whether people who think they've seen aliens, whether they see them as green or blue. Said like that, I hope it's obvious that doing a meta-analysis of the trials of whether they're green or blue would be laughable. But the way RCTs are used is almost equally laughable because they're completely divorced from any reality of basic science and whether the proposed treatment has any scientific foundation. And most clinical medicine comes from the foundation of all those underlying sciences. It doesn't just come out of the blue. Somebody doesn't just produce a new tablet, throw it to a few people and see if they can prove it's better for ingrowing toenails or bat ears or what the hell, And so the whole thing becomes silly. It's rather unscientific in my opinion. So RCTs are a limited methodology for establishing whether a treatment like that works. And that applies just as much to MAOIs in severe depression as it does to ECT. And it becomes a kind of self-fulfilling circular argument. Monoamine oxidase inhibitors don't appear in the guidelines. Most guidelines for ECT don't even mention the possibility or advisability of trying a course of MAOIs first, and so on and so on. And if they're not in the guidelines, people don't use them. And if they don't use them, nobody does trials on them, so they're not in the guidelines. It's a circular argument. And I think in my professional lifetime, it's produced a stultifying effect on the whole of medical research, but especially in our field of psychopharmacology. I think it's been very negative. I'll finish by reminding everyone, having just said that if you look at all the major advances made in treatments in psychopharmacology, all of them, I can't think of a single exception to that, at least at the moment, perhaps somebody else will, but all of them, or almost all of them, have come out of serendipitous observations, whether it's MAOIs, lithium, tricyclics, sodium valproate, clozapine. I think the list is pretty long. None of those advances have come from randomized controlled trials. People say, but you've got to do a randomized controlled trial to prove it really works. Nonsense. That's not the case. And that's where we get back to the whole business of epistemology, the study of logic and knowledge in science. And that, I think, is where people have become bamboozled. Generally speaking, clinicians have become bamboozled into believing that if it's not been shown by a randomized controlled trial, then it's meaningless and it's not true. And that is a huge misconception, an enormous misconception. All right, I think I shall wind up there. Anybody who wants to engage in further comment and discussion about this, I don't encourage them to do that via comments on YouTube, because we don't use those as a forum for this sort of thing. Write to us on the website and look at the detailed information on the website before you make a comment, because the better informed your comment is, the more helpful it'll be to everybody. And I hope you find it interesting and enjoyable. There's some really interesting stuff there. And lastly, please consider supporting the efforts of the website, because it's substantially devoted to the whole business of educating people about MAOIs, trying to encourage doctors to use them, because if they're not used, they will fall out of use. And that's the business that's been happening with Nardil, phenelzine, in this last few months. One of the major factors in its reduced availability and the danger of it actually ceasing to be available is not enough people are using it. And drug companies and people who produce the active pharmaceutical ingredient, they're not going to manufacture it if nobody wants to use it. You can't expect them to be charity organisations. Maybe governments should have their own laboratories to produce out-of-patent drugs. That's quite a good idea, probably, but that's not happening at the moment. So there you are. It's food for thought, and please consider supporting what we're doing, because what we do costs money. So if you're in a position to make a donation to help us, then consider that, and have a good look at the website and the references and extensive information on it. Goodbye for now.